So welcome everyone, welcome to our second part of minor illness webinar. We've got three speakers today. We've got Freddie, advanced paramedic practitioner, who's going to be talking about common foot and hand conditions. We've got nurse Christina from James Wood Practice. Freddie's also from James Wood Practice, and Christina's going to be talking about common minor injuries. And Dr. Anir Renukantan, who's going to be talking about common infections. Now got Dr. Anir Renukantan.
Hello, yes, thanks, Staloni. Hi, everyone. I'm Dr. I'm Anir. I'm one of the GPs at Prince of Wales Medical Centre, and I also work at the UCLH Urgent Care. I am going to be talking to you today about common infections that we encounter in primary care. So, next slide, if that's okay. Thank you very much. So, and next slide again. So we're going to start off by talking a little bit about upper respiratory tract infections. So in the course of my talk, I thought what would be really useful is to actually sort of think about these common infective presentations from a more sort of a broader perspective, in the sense that often we encounter these so commonly that I feel it can lead to many common pitfalls and things, sometimes wider differentials being missed. So in the course of kind of talking through these common infective presentations, I want to give you all a sort of a sense of a spectrum of conditions in which they can present, and try and engage your thoughts to think about differentials as we go on to talk through the different topics. So what is an upper respiratory tract infection? How do we define it? So essentially it is an inflammation or an infection of the upper respiratory tract. So that includes the nose and the throat and the upper airways of the chest. And it's most commonly associated with what we call the common cold, and it's usually viral in nature. As we know, it can be caused by common viruses like rhinoviruses, adenoviruses. However, of course, in the current pandemic, we've got to think about these symptoms in the context of COVID. So maybe whilst a year ago we may have sort of reassured the patient to sort of with a lot of self-care. In the current climate, we're having to think about some of these atypical viral features being consistent with a potential COVID like illness. So as you can see, some of the symptoms on the slide are the most common symptoms you may expect with an upper respiratory tract infection: fever, runny nose, sore throat, cough, headaches. But remember that the upper respiratory tract infection can present with more widespread systemic symptoms. So they can be part of a prodrome of viral gastroenteritis, so diarrhea, especially in children. But they can also be associated with dermatological presentations with interesting rashes like pityriasis rosea. But also, it's important to think about upper respiratory tract infections as often a prelude to conditions that can happen later on. And this is why it is important in primary care that we acknowledge that we only have a snapshot of the patient that we either review over the telephone or face to face. And so safety netting becomes all the more important. Next slide. Thank you. So how do we assess someone with an upper respiratory tract infection? So in part of taking a full history, we want to get a sense of a duration. So most upper respiratory tract infections will tend to occur within a duration of days to weeks. And remember that things like the cough can last up to sort of 3 to 4 weeks. However, how do we assess for this reliably over the telephone and ensure that our patients do not have any differentials or red flags for more serious untoward illnesses? It can be quite tricky. So previously, when we were seeing a lot of face-to-face, we would do a full set of vital signs. We'd see the patient walk into our rooms. We could do the end of room inspection. Are they talking full sentences? But how do we do this over the telephone? And that's why I think with telephone consults, it's important to think about more sort of subjective measures. So how different is it from the patient's baseline? Are they speaking full sentences? Is it impacting on their activities of daily living? How far can they walk? Are they able to walk up the stairs? These kind of measures can really help in your risk assessment. If we were to see them face to face, as we potentially do more of in the A&E setting, I still do see patients with features of upper respiratory infections in the urgent care, and we might want to do a full chest examination, as well as examine their ears and their throat and do their vital signs. It's important to think about important red flags. So upper respiratory tract infections can often present as part of a spectrum of respiratory illnesses, including pneumonias or exacerbations of pre-existing lung disease. So it's important to do a risk assessment and think about whether they have any issues with their breathing, whether they have any features of sepsis, such as the reduced urine output, or are they drowsy, or do they have any cool peripheries? So what kind of differentials do we think about when we that go through our mind when we see someone or speak to someone with an upper respiratory tract infection? So I think the common one that we all want to often exclude is, or the common question that we ask ourselves is, does this patient need antibiotics? Do they need to go into hospital? So, often the point I want to try and get across is that because we see these presentations so commonly, we can start to develop a certain sense of bias, or an unconscious bias, where we start to get used to sort of thinking, oh, it is just a common cold, and we may tend to kind of go down the lines of reassuring patients. Do remember that pneumonias, such as atypical pneumonias, can present with things like a dry cough. They can get headaches, they can get myalgias. What do I mean by things like atypical pneumonia? So these are chest infections or lower respiratory tract infections caused by atypical organisms like Legionella or Mycoplasma. So what I mean by this is often we may tend to jump at the fact that just because a patient doesn't have productive symptoms, they may just have a viral upper respiratory tract infection. But remember that they can have atypical chest infections. It's important to think about differentials such as, do they have pre-existing asthma? Do they have pre-existing COPD? Have a look at their EMIS records before we consult them, just to see, is this maybe an exacerbation of a pre-existing condition? As I said, remember, upper respiratory tract infections can precede more serious illness such as sepsis or meningitis, especially if it can start off as a sinusitis and progress onto these more acute concerning presentations. So it's important to safety net patients about calling us back if the symptoms do not improve. Next slide, please. Okay, so how do we manage a patient who we think, based on our history, our risk assessment over the phone, it's very likely upper respiratory tract infection. It's likely viral. The important thing, first of all, in the current climate, I'm sure you'd all agree, is to make sure that we get a COVID test. And I'm not going to spend much more time talking about COVID in this presentation, but one of the loopholes we often have, and I've experienced this with patients that call us up, is, doctor, I don't have a loss of sense of smell or taste, I don't have the cough, I don't have the fever, so I don't think it's COVID, I haven't got a COVID test. What we're finding in the last few months, especially with the new strain, is that people are having lots of atypical presentations of viral respiratory tract infections. So people may have, sinus symptoms, people may have headaches, people may actually have other viral prodromes such as diarrhea. So it's important to just have a broad and open mind in the current pandemic and think about doing a COVID test, so that we can ensure that these patients are appropriately isolating and are appropriately risk assessed because of the risks associated with COVID. Now, if they've either had a negative COVID test, or we're thinking this is just a common cold, or it's likely to be a rhinovirus, the important thing is, what can we do to empower our patients and make sure that they manage their symptoms as best as possible? So as we know, it is viral, so their immune system will ideally fight the infection. However, it's important they keep hydrated, and then we advise them to keep a healthy, balanced diet. The NICE guidelines actually recommend, considering simple analgesic methods like paracetamol, ibuprofen. And it talks about using self-help measures, which we'll go through on the next slide. But I think the most important thing to take away from common presentations that we might see in primary care, such as the upper respiratory tract infections, is to make sure that we do appropriately safety net them, and we don't just fall into the trap of, being dismissing it as a simple cough or a cold, thinking about the fact that it can progress into a pneumonia, it can progress into other things, and appropriately safety net patients. It's more important than thinking about those who are at risk. So the NICE guidelines actually talk about at-risk groups. So particularly with those at extremes of age, so those in the neonatal period or infants, because you might be thinking of other forms of upper respiratory tract infections, such as bronchiolitis, where they may need not just supportive measures, but perhaps even hospitalization, depending on how they present. But also older adults, so adults over the age of 65 who may have an atypical presentation of a pneumonia. It's important to think about smokers. As you may be aware, cigarette smoke can affect the cilia and can impair the ability of an individual to actually clear up their sputum in their airways. So these individuals can be at more risk of having bacterial chest infections. It's important to think about the immunosuppressed. So especially if you've got an individual who is HIV positive and you know that from your EMIS records, think about those rare chest infections or those presentations like PCP, which can present with sort of atypical pneumonias. It's also important to think about those with, severe comorbidities that affect the heart or the lungs. So those who have congestive cardiac failure or chronic kidney disease, and those with lung conditions such as COPD, asthma, and cystic fibrosis. So next slide. Thank you. So an interesting thing when I was going through this talk was that we often recommend a lot of self-care remedies to patients, and it was interesting to really think about what is actually NICE approved and what isn't really NICE approved. So we often, in consultation, I'm not sure about yourselves, but we may recommend things like honey and lemon for a sore throat, steam inhalation. And interestingly, actually, NICE has approved these as self-care remedies. So we can use things like steam inhalation, we can use vapor rubs, saltwater rinses. The important thing to note is that the evidence base for this is quite limited. However, it's not to say that on an individualistic basis that patients may or may not find them helpful. And actually, they can be quite helpful symptomatically, and they are approved by NICE. So these are things that we are well within our right to advocate for patients. Next slide. Great. So just coming back to what I sort of said at the start of my talk is to think about the conditions as part of a spectrum as opposed to a distinct entity. So remember that presentations can always change and progress onto other kinds of conditions. So it's important to think about the upper respiratory tract infection in the context of, is this part of an evolving condition? Is it part of a pneumonia? Is it part of an ongoing sepsis presentation? Or is this just something that we can manage at home with appropriate safety netting and follow up? So interestingly, NICE has listed the kind of features that may make you think about using antibiotics. So as opposed to thinking about whether it's a viral cough versus a pneumonia, it thinks about using their risk criteria. Are they at high risk of complications? Are they systemically well? And using those as factors to help you decide whether they need antibiotics. I often like to, with all patients, like to think about this question: are they well versus are they unwell? And also thinking about all the comorbidities that we've talked about on the previous slide. I'm not going to go into pneumonia into too much detail, but if you are worried about someone with a lower respiratory tract infection, you can use risk stratification tools like the CURB-65. What do I mean by CURB-65? So are they confused? Do they have a high respiratory rate, low blood pressure, or are they over the age of 65? It's a tool that we use in primary care to decide with people who have a low respiratory tract infection, are they at risk of hospitalization? Can we just manage them at home with oral antibiotics? Without going too much into antibiotic choices, remember our first line tends to be amoxicillin, but if we're thinking about atypical pneumonias or chest infections, we might consider doxycycline, which has better cover for atypical organisms. Next slide. Brilliant. So really, Upper respiratory tract infections, that was sort of just a breeze through thinking about common features of an upper respiratory tract infection. Now remember, the upper respiratory tract infection is really common, so that in adults it's estimated from a recent study that it's about 2 to 4 presentations a year, and in children we can expect sort of 6 to 8 presentations a year. Now, alongside the upper respiratory tract infection, it could be useful to think about presentations of an acute sore throat, which is something that we commonly encounter in primary care. How do we go about assessing the patient with the acute sore throat? Yes, of course, it's something that we often associate with tonsillitis, but it's important to remember that there are other causes of an acute sore throat, and once again, not just assume that it's likely tonsillitis. What we'll want to do is think about other differentials. So remember that if there's more of a subacute history, if there's a presentation of fevers, a sore throat over several weeks, fatigue, you may want to think about glandular fever, which is a viral infection caused by the Epstein-Barr virus, and it's common in younger individuals, younger adults. We might want to think about reflux or an acute esophagitis as a cause of sore throat symptoms. It's important to think about red flags such as malignancies, hematological malignancies, or even rare cancers like laryngeal cancers, tonsillar cancers. And we can talk about how we might identify features of those as opposed to thinking about an acute tonsillitis. So what causes a tonsillitis? So we know that 90% of tonsillitis, acute tonsillitis, are caused by viruses in origin. So the same viruses that tend to cause the common cold, the upper respiratory tract infections, so rhinovirus, adenovirus, and they're part of the upper respiratory tract infection spectrum. So if we're pretty convinced from the history, which we're focusing on by telephone consults now, we may want to use a period of self-care monitoring, advising the patient with simple remedies like warm salt water rinses, ibuprofen, paracetamol, these kind of things, and advising them to kind of monitor it. However, remember that 10% of tonsillitis can be caused by bacterial infections, particularly group A strep. And this is the common bacteria which we would use to treat tonsillitis with 10 days of penicillin-based antibiotics. And as I mentioned before, do think about other causes of infective presentations of a sore throat. Next slide, please. Okay, so we're going to take a full history. We want to know, as I said, with the upper respiratory tract infection, when we're assessing them over the phone, are they well? Are they unwell? How much is it impacting on their hydration status? Are they able to swallow? If I'm presented with a young individual who cannot even swallow water, I'm slightly more concerned and more inclined to get them referred into on-call ENT and to get some urgent ENT input. Is it affecting their breathing? Are they getting any hoarseness in their voice? You can see that I've mentioned on the slide things about medication history. So important loopholes to think about when we assess the sore throat is to think about, are there any drug or medication causes of a sore throat? So remember that certain people who take medications such as carbimazole or methotrexate, or people who are on chemotherapy, a sore throat can be an important finding to elicit in people who are on these medications, because it can be a presenting feature of something called agranulocytosis or neutropenia. Or in the context of someone on chemotherapy, it might be a presentation of neutropenic sepsis. So it's important just to make sure that we look at EMIS or whatever medical systems we use, make sure we have a look at their medications, their medical history, and put it in the context of their symptoms. Examination, which we're doing less so in primary care, given it's the current pandemic, but very recently in my urgent care role yesterday, I saw a young individual with a sore throat. We'd use full PPE, we would do a full sort of ENT exam and examine their lymph nodes, just to check for other features of an associated tonsillitis. Next slide, please. Okay, so NICE have given us some really useful criteria that we can use once again to ascertain the likelihood of a sore throat or an acute presentation being bacterial versus viral. So once again, just similar to the upper respiratory tract infection, it suggests that we need to be thinking about these presentations as part of a spectrum as opposed to a distinct entity. Now, there's two sets of criteria that NICE have suggested that we can use to help aid our assessment. So traditionally, when I've worked in A&E, we've used the central criteria, where we have 4 characteristics: fever, pus on the tonsils, anterior tender cervical lymph nodes, or the absence of a cough. However, more recently, we've reverted to using something called the fever pain criteria, which you can see on the left-hand side of the screen, which has 3 of the same features of the central criteria, but also the fourth feature is that they've mentioned is a patient who presents very quickly or who have severely inflamed tonsils, so very red inflamed tonsils. But essentially, if you have at least the higher the criteria with the central criteria, the fever pain criteria, the more likely you think that they may be suffering from a bacterial tonsillitis and would benefit from oral antibiotics. Traditionally, we use 10 days. The recent NICE guidelines say that we can, if we can use 5 to 7 days, but sometimes this may not be enough to completely resolve the sore throat. So essentially, using this criteria is very helpful to decide the likelihood of it being a viral tonsillitis as opposed to a bacterial tonsillitis, and the need to prescribe antibiotics. As you can see from the little prose taken from the NICE guidelines, with criteria being in the middle, you could even consider a backup or a delayed script for an antibiotic, which I've done, which I tend to do as well. And that's a really good way of doing a bit of shared decision making with the patient and sharing that management, sharing that risk with the patient. Next slide, please. Right, so thinking about pitfalls, which I really wanted to kind of think about this presentation. We've already talked about medications and being quite thinking broadly about putting a patient's sore throat in the context of any medications they might be on. It's important, commonly, classic sort of an exam question, to not make sure you prescribe amoxicillin for a sore throat. And the reason is because generally with prescribing amoxicillin, if the sore throat happens to be caused by something called glandular fever or Epstein-Barr virus, as you prescribe amoxicillin, they can present with a macular papular widespread rash. So it does happen commonly, and it still very commonly happens. And what often patients tend to think about is they tend to think that they're allergic to the amoxicillin, whereas what may have likely been the cause was that they'd been prescribed this for sore throat, and they've had a reaction to that appropriately. What other red flags do we need to elicit when we're assessing someone with a sore throat? So as I said, when they present acutely, we need to think, are they systemically well? Are they well hydrated? Are there any features of sepsis? I've definitely encountered some young patients who have severe pus on their tonsils, really poorly responding to antibiotics. They might be tachycardic, very, almost septic. These kind of patients may very well need to be assessed in A&E by the on-call ENT team. Sometimes the ENT team may use things like dexamethasone to reduce the swelling in the tonsils. You may want to assess for something called quinsy, which I will talk about in the next slide. The other thing to be really important to take into consideration is about, as I mentioned previously, is appropriate safety netting. So generally, sore throats should get better and should improve. So if an individual has a persistent sore throat, we do want to look into this. We do want to kind of identify why this may be the cause, because rare presentations such as tonsillar cancers, laryngeal cancers can present with a persistent sore throat over 3 weeks. And this is included as part of the head and neck ENT 2-week wait criteria. So that's why it's important to safety net these patients accordingly. In terms of red flags, if someone's got a persistent sore throat, you may also want to think about other aspects such as weight loss, night sweats, fevers, and these may suggest presentations of malignancy such as hematological cancers like leukemias, lymphomas, and sort of other kind of malignancies as well. So these are things to really elicit when someone presents to you with a persistent sore throat. You may want to then think about doing some blood tests, a full blood count, to assess this further. Next slide, please. Okay, so generally my slides, when I've put a slide in red, it means it's to think about a potential serious differential to think about when you're assessing a common presentation. So this slide's in red because when you're assessing someone with a tonsillitis or someone who might be a little bit slow to resolve with antibiotics and is still having fevers and a sore throat, you may want to think about something called a peritonsillar abscess, which is where they tend to get a buildup of pus or swelling in between the posterior pharynx and the tonsils itself. And they can present with something called a hot potato voice. They may get something called trismus, which is where they get unable to open the jaw. They may get drooling and halitosis, which is where they can get an odorous breath. So in these kind of situations, they often need to be seen in A&E by the ENT team and will likely need intravenous antibiotics and may very well need some kind of surgical management to drain all that pus that's built up. And as you can see from the picture, it generally presents with this sort of unilateral swelling that is pressing on the tonsils. You may get some deviation of the uvula, as you can see in the photo. Next slide. Great. So that was just really a whirlwind tour of thinking about upper respiratory tract infections and tonsillitis. And essentially, as I mentioned, it was really just to think broadly about, when to really kind of think about alternative presentations, and also when to think about whether they're unwell, whether they're septic, and when to sort of really consider sort of hospitalization. We're now going to move to a different part of the body and think about urinary tract infections. Once again, a very common presentation that most of us probably encounter, probably see at least 4 or 5 consults with UTIs on my duty list on a typical day. On face value, these kind of consults may seem on face value like they're very sort of simplistic, and it's very common presentations, just do a urine dip, give antibiotics. But actually, what I hope to achieve from this talk is to think about that there are more broader things to think about in the context of simple urinary tract infections. So what are the common symptoms? So most urinary tract infections are, of course, very common in women of all ages, and it's due to an anatomical difference between women and men. Women tend to have a shorter urethra, which predisposes them to have more common urine infections. And most female patients that I've spoken to who tend to have recurrent UTIs are very familiar with their symptoms. So they may call and they will tell you that it feels like they're normal urinary tract infections. And this can really help in your history taking over the telephone. So common features are dysuria, burning or stinging when they pass urine, or a feeling like they're passing razor blades. Frequency, where they're feeling they're having to rush to and fro to the toilet. Sometimes they may just describe some changes in the consistency of the urine, so it's either cloudy or more foul smelling. They may have some blood in the urine, and they may have some discomfort suprapubically. It's also important, though, to think about urinary tract infections in our older population, where they may not present with your typical symptoms. And it's important to think about in those patients who may be deteriorating cognitively over a number of weeks, or who present with an acute confusional state, so thinking about delirium or disorientation in frail older individuals. Next slide. Okay, so what are the common causes of urinary tract infections? So as I mentioned, there are common predisposing factors, but actually urinary tract infections are bacterial infections. And if you remember from our traditional teaching of microbiology, we have something called the Gram stain, which is a crystal violet stain that has been used for hundreds of years, still used by microbiologists in the lab to stain the bacterial cell wall. If a bacteria is gram positive, then they will have a cell wall will retain the purple stain, and then they are gram positive. If they're gram negative, they won't stain purple. Why am I mentioning this in the context of this presentation? Why is this relevant? it's really useful to have an understanding of causes of infections, and whether they're gram-positive or gram-negative, because it does help inform what kind of antibiotics you may feel may benefit patients with certain types of infections. So urinary tract infections are most commonly associated with gram-negative bacteria, and traditionally most common gram-negative bacteria that causes urinary tract infections are things like E. coli. But remember, there can be other atypical organisms like Klebsiella, or even in resistant urinary tract infections, they can be organisms like Pseudomonas that can cause these kind of infections. As you can see on the screen, there are lots of common kind of triggers. So there are some ladies who tend to get them immediately after intercourse, dehydration. They're incredibly common in pregnancy, and that's felt to be due to the urethral dilatation, the dilation of the ureters, where they seem to get a little bit of hydronephrosis, and this can cause a buildup of stagnant urine and urine infections. Other predisposing things to think about in common urine infections are those with structural abnormalities, so those with known kidney stones, known renal stones, or known kind of structural abnormalities like strictures, but also commonly in presentations such as constipation in younger children who may be more constipated or who have an enlarged prostate, and those who have catheters. So these kind of things are common presentations. Okay, next slide, please. Okay, so it's important to think about it. Typically, taking history from a patient with a urinary tract infection, one might think is a very quick. It's very quick. It's very, it's a simple case of getting the symptoms elicited and prescribing antibiotics. But it's actually important to remember that sometimes things can be easily missed, because presentations of UTIs can actually mimic features of other very common conditions, and even sometimes more serious conditions. So when I take a UTI history, most commonly I do want to always exclude pyelonephritis. So traditionally they'll have loin pain, they may have fevers, or they may be vomiting. And that may also be part of a spectrum of urosepsis. So you may want to just check whether they're eating and drinking, are they feeling well in themselves, safety net them appropriately. You may want to then think about other causes. So it's important to, very briefly at least, just think about gynecological causes, including sexually transmitted infections. Things like infections like chlamydia can present with dysuria. Pelvic inflammatory disease can present in this way. Pregnancy can very commonly present with urinary frequency, so it can be a particularly challenging situation in which in diagnosing UTIs, because pregnant ladies can have urinary frequency, but they can also have associated UTIs as well. But also thinking about fibroids, which can sometimes press on the bladder. Other things to think about are red flags. So in someone with recurrent UTIs or persisting hematuria urinary symptoms, or a constellation of vague abdominal symptoms such as bloating, pelvic pain, we need to think, especially in the older population, we need to think about our bladder, ovarian, and other gynecological cancers as well. And remember that sometimes, especially in the postmenopause population, conditions such as atrophic vaginitis, which respond very well to topical estrogens, these kind of presentations can also mimic UTIs. So we'll definitely talk about how we can assess these patients better and how we can manage these patients. Next slide, please. So how do we assess them? So the NICE guidelines relies on taking a good, solid, thorough history of the urinary presentation, thinking about previous UTIs, previous MS, midstream urine sensitivities and previous treatments, previous antibiotics they may have had. So the guidelines have changed every few years, but they do still suggest that using urine dipstick can really help aid a diagnosis. Now, remember, guidelines are only guidelines, and they're not necessarily the be-all, end-all, but they are there for us to help support us with our assessment and management. So a urine dipstick may not always be entirely accurate, and I have definitely picked up E. coli presentations in ladies who have an almost near normal urine dipstick. So if you're really concerned about the symptoms, I would often treat and send it off as an MSU. How do we interpret the urine dipstick? So if they have nitroids and leukocytes, it really helps reinforce that it's likely urinary tract infection, and we can start antibiotics empirically with 3 days of treatment. Now, if they've got leukocytes, you may want to send it off as an MSU, and depending on the extent of symptoms, you may want to treat. Now, if they've got negative urine dipstick, then there is a high, in the absence of good going urinary symptoms, it's less likely. Next slide, please. So as you can see, we're very lucky in Camden. We've got the amazing Camden GP website, and we've got an actual pathway that is pretty much based on the NICE guidelines that tells us exactly when to kind of consider a urine dipstick and what are our first line management options for a urinary tract infection and when to start antibiotics. So I'd encourage you to all have a look at this in your own spare time. Next slide, please. Okay, so it's quite interesting because different colleagues have a different sort of threshold as to when they want to send off a midstream urine sample. And I think when in doubt, just send it, because it's an incredibly helpful test. It gives us sensitivity. So I often find that even if patients represent or have recurrent urinary tract infections, especially, so at least 2 in 6 months or 3 in a year, it's very helpful. It's also very helpful if their symptoms have not resolved. Remember, we cannot rely on urine dipsticks in the population above the age of 65. So in this situation, we may want to just send off a midstream urine. We want to send it off in pregnant women, specifically actually because sometimes they may not have symptoms, and we need to check for something called asymptomatic bacteriuria, which I'll talk about on the next slide. We may also want to look at it in what we call complicated urinary tract infections. So this is when they've got any structural problems like kidney stones, or they've got an indwelling catheter, or they've had recent hospitalizations, anything where that puts them at slightly increased risk of having a urinary tract infection, or if they've got any sort of hematuria. Next slide, please. Okay, so the management is actually quite interesting because we've got to bear in mind that NICE has very clearly set out very focused management depending on the actual presentation. So there isn't a one size fits all approach here. So typically in your young, fit, well, healthy female with no signs of pyelonephritis, with a simple lower urinary tract infection, we may use a urine dipstick, and if we've got a good idea that they've got a urinary tract infection, we'll prescribe 3 days of antibiotics after thinking about the risk of complications with nitrofurantoin. But it's important to make sure we appropriately safety net them, to return to contact us if the symptoms don't resolve or if they have any features of pyelonephritis. Next slide, please. So urinary tract infections in pregnancy can be an area of anxiety. It's really important to pick up, and the reason is, as you can see on the slide, there are risks to both mother and fetus from urinary tract infections or even asymptomatic bacteriuria. What do I mean by asymptomatic bacteriuria? So these are spot midstream urine samples often sent by us or the antenatal team, where patients may often not have symptoms, but they may be found to have more than 10 to the power 5 colony-forming units of a form of bacteria in the urine. And we would still treat this like a urinary tract infection, and we would tend to cover them with 7 days of antibiotics. And we would, depending on what we identify, we would alert the antenatal team. So commonly we might pick up things like group B strep, which is an important organism to inform the antenatal team about, because it affects risk factors for sepsis in labour, for maternal and neonatal sepsis. So that's thinking about it from an asymptomatic bacteriuria point of view. What are the risks in pregnancy from UTI? So to mother, there can often be a risk of preterm labour. They can have things like chorioamnitis, but for the baby, they can often have low birth weight. They can have intrauterine growth issues. So these are things to think about. And the other thing to think about in pregnant ladies, because they are slightly more immunosuppressed, they can be at a slightly higher risk of pyelonephritis. So these are the risks that are really important to think about. Now, interestingly, NICE guidelines actually suggest that we if we suspect a urinary tract infection in pregnancy, that we give an immediate antibiotic prescription for 7 days and we send off the MSU. So we can use nitrofurantoin except close to term because there's always a risk of neonatal hemolysis. So we tend not to use that close to term. It's important to safety net pregnant ladies, and if things are not resolving, is to get some specialist advice, or if there are recurrent atypical bacteria or structural problems that we know about. Next slide. Okay, so recurrent urinary tract infections, once again, are really common. So this tends to be, so what is defined as recurrent is if it's more than 2 in 6 months or 3 in a year. Generally, there is no sort of stated figure as to when we should kind of consider referral, but I would, from my experience, I would say that anything more than sort of 6 to 8 times a year, you might want to start thinking about structural causes to urinary tract infections and think about urology input to identify any structural causes. It's important with your recurrent urinary tract infections to think about whether the patient meets any referral criteria by 2-week wait. So do they have any frank hematuria above the age of 45, or is there any persistent hematuria in the above age 60, or are there any features of ovarian cancer, so urinary frequency with pelvic pain? You may want to consider a CA125 and an ultrasound. So it's important just to think broadly with patients who present at a certain age with recurrent symptoms, because there may be something structural going on. If with recurrent urinary tract infections, we can consider prophylactic antibiotics, but this is only after we have investigated for a cause for it. And as I mentioned, if we think that there are features of atrophic vaginitis or postmenopausal irritation, we can consider topical estrogens with Vagifem. We may also want to consider good lifestyle measures, so just general hygiene, and also thinking about common things that can affect the urinary tract system, so adequate hydration, avoiding excess sort of alcohol, caffeine, all of these things that can really cause recurrent urinary symptoms. Next slide. So UTI in men. So once again, this can also cause a sense of anxiety because generally urinary tract infections are less common in men than they are in women. And I suggest that men are at least allowed to have at least one urinary tract infection without requiring further investigation. But if they have 2 in 6 months or recurrent UTIs, or you suspect structural causes like surgery, previous operations, or previous kidney stones, then you may want to refer to urology, or if their symptoms are not improving with antibiotics. You will want to treat them for 7 days, and you'll want to send off an MSU. A common pitfall to think about in men is to think about an alternative presentation called prostatitis, which is where the prostate gland, which is the gland beneath the bladder that produces semen, in men it can be inflamed and can be infected. Remember, there's acute and chronic prostatitis, and it tends to present with this perineal pain. So they get pain between the genital region and also the back passage, and they may have extreme discomfort sitting down. Sometimes this can progress into things like an abscess, so they can get a boggy swelling. I'm slightly going off on a tangent here, but it's just to make you think that if you are consulting with a male patient who is having sort of persistent kind of urinary symptoms, you may want to just check on features of prostatitis. You will want to send off the urine off as an MSU, and if you're worried about prostatitis, you will want to ideally try and examine them from the back passage to check for any features of a prostate abscess. And it also just affects what antibiotics you're going to prescribe. So if we're worried about a prostatitis picture, we may actually treat them with something called ciprofloxacin for 2 weeks at least, possibly even longer. Whereas if we're worried about more of a simple urinary tract infection, we may go for nitrofurantoin. The other thing to think about in the acute picture is to understand, are they systemically well versus unwell? Do they have any fevers? Are they vomiting? Do they sound septic over the phone or from assessing them? Because that's when you may consider admission. Next slide. Okay, and then commonly catheter-associated UTIs are actually more common, and we do encounter them. So we would send off a midstream urine sample from the catheter. We would lightly cover with 7 days of antibiotics. Once again, it's nitrofurantoin. We often need to check the indication for the catheter in the first place. So, we might want to check whether the patient needs the catheter. Can they be seen in the TWOT clinic? Does it need to be changed by district nurses? Is there any blockage? So all these things can increase the likelihood of a urinary tract infection. Now, if a patient's catheter-associated UTI is not improving, or they're getting any atypical bacteria cultured in the urine, or there's worsening symptoms, we may want to get some specialist advice from the urology team. Any next slide? Great. So I know it's a very busy slide, but this is just a really useful snapshot from the NICE antimicrobial guidance, which I tend to have open during every clinic, every duty session. I tend to have it open. It's a really useful resource because it's got a whole summary of all the different antibiotics and even some of the assessment criteria that you might use for common infections. So I'd encourage you to have a look at this in your own time. Next slide. And I've got a nice red slide, so thinking about red flags or acute presentations. So pyelonephritis, remember they can get this sort of flank pain, fevers. It's which may coincide with some features of a lower urinary tract infection. The challenge I often find, and I'm sure most of you would agree, is when you take a history from a patient and they say that they've got back pain, but they've got chronic back pain, and how do you decide between acute pyelonephritis versus an exacerbation of their chronic back pain that's happening at the same time as their UTI? And it can be incredibly difficult to ascertain over the telephone. I would say that the other features like fevers or vomiting and these kind of features can aid your assessment and your risk assessment. The other thing to think about is if you are able to assess them in person, then you can examine for something called costovertebral tenderness or renal angle tenderness, which can also help be a sign that you can elicit with pyelonephritis. Now remember, we can manage pyelonephritis in the community, so if patients do not appear systemically unwell and they're able to eat and drink and they're managing, we can give them oral antibiotics, and we tend to use cephalexin. The cephalosporins are very good for 10 days. But if they're not responding, or they're feeling more unwell, or you're worried about sepsis, then they are likely to need acute admission for urgent intravenous antibiotics and bloods. Next slide. Great. So we've just done a bit of a whirlwind of urinary tract infections. I'm conscious that we're almost towards the end and running out of time. So vaginal discharge is a common presentation we've seen in primary care. Once again, just to think about, we tend to immediately sometimes can make assumptions about it being BV and thrush, but it's important that the devil's in the detail. It's important to take a really thorough history, more so over the telephone because we aren't able to see patients in face to face. So it's useful to get a really solid history about the colour, the consistency. And I often like to ask about change in discharge because vaginal discharge is incredibly common. We know that many women may experience physiological discharge at times of menarche, which is when they are starting their menstruation, or around the menopause, or certain types of their cycle. So it's useful to know, how has your discharge changed? Is there any odour to it? You want to know, is there any associated pain or itching or any urinary symptoms? But most importantly, it's very important, I think, to always just touch base with a sexual health history. Make sure you signpost patients and do not feel anxious about trying to get the details, because it's very well that patients may have other causes to their vaginal discharge, like sexually transmitted infections. Remember, there can be other triggers, as I said, such as related to their cycles or contraception. But also, if we're worried about things like pelvic inflammatory disease, we might be thinking about bleeding or pelvic pain. One thing that I noticed on preparing this teaching was that actually vaginal discharge is a red flag criteria in someone over the age of 55 when you are worried about endometrial cancer. So typically with endometrial cancer, we tend to worry about postmenopausal bleeding being the common presentation. But the NICE guidelines suggest if someone's over the age of 55 with persisting vaginal discharge and they've got either high platelets or they've got some blood in their urine, you may want to think about things like a vaginal ultrasound scan just to exclude an endometrial cancer, because it's a bit strange to have persisting vaginal discharge with normal sort of swabs. If symptoms are slow to improving with antibiotics, you may want to consider examination with vaginal swabs. Now, there's lots of causes that you can see on the bottom of the slide, from physiological causes to BV to thrush, common infections, but also the sexually transmitted infections like chlamydia, gonorrhea, and trichomonas. Things like retained tampons, like foreign bodies, can cause it, as well as local kind of irritation to deodorants and soaps. But also postmenopausal causes such as atrophic vaginitis can cause it, as well as malignancies such as cervical and endometrial cancer. So it's important just to have a broad mind when assessing these. Next slide, please. Great. So in terms of the management, this is one of those areas where NICE has actually very explicitly stated that we can treat empirically without having to examine patients, especially if we're not worried about a sexually transmitted infection, or if it's not related to any recent kind of invasion of the vaginal tract, so either through surgery, through a recent miscarriage, or through termination. The reason why they've said this is because if you are getting vaginal discharge or foul discharge after these kind of procedures, then it may suggest possibly an endometritis or an infection locally that needs to be kind of examined. So that's why they've included these. The other time that we can think about just treating them empirically is if it's a first episode or if they're not pregnant. Next slide, please. So vaginal candidiasis. So how do we treat thrush? Thrush is incredibly common, especially in young women from the age of sort of 18 and above, all the way to women who are much older. Typically presents with that thick, white, creamy discharge and has associated itching, soreness. Women can sometimes get some stinging of their urine. They can get something called superficial dyspareunia, so sometimes there can be a little bit of pain on sex. There are some risk factors for it, so it's more common in ladies who are pregnant or who have diabetes or who have a suppressed immune system, but it can be also more common with certain forms of contraception, so an estrogen exposure at certain times of their cycle. And although it's not a sexually transmitted infection, recent sexual intercourse episodes can predispose to thrush infections. So a bit similar to urinary tract infections, there is a slight tailored approach to the patient in front of you. So typically, most of our general population are quite well informed and may tend to, by the time they've called us, may tend to buy over-the-counter Canesten, either the creams and the pessaries, and they may have tried this already. But if they haven't, then we can definitely prescribe this, especially if they're pregnant. This would be our relatively only option because we cannot use oral antifungals in pregnant ladies. If the symptoms are more severe or persisting, then we can consider some swabs, and we can do an induction regimen with oral fluconazole, 150 milligrams, 3 days apart. And often, together with the topical treatments, this in itself can make a massive difference in treating the thrush. If we're worried about recurrent symptoms, so there are unfortunately some ladies who suffer with recurrent symptoms, then we may want to consider a maintenance regimen, which is in keeping with NICE guidelines, where we consider either oral or topical treatments once a week for 6 months. And we can use oral fluconazole or topical clotrimazole. In the immunocompromised individuals or with poorly controlled diabetes, we may once again also want to consider a slightly prolonged course. Next slide. And then we want to just talk briefly about bacterial vaginosis. So remember, bacterial vaginosis is a common vaginal infection. It is not a sexually transmitted infection, but it is an infection that is more common in sexually active individuals. Typically, 50% of women are often asymptomatic, but if it does present, they may present with just thin grey discharge with a fishy odour. And you can test the vaginal discharge by putting a pH strip, and the pH is often above 4.5. This can be very similar to an asexually transmitted infection called trichomoniasis, which also the pH is above 4.5. But with trichomoniasis, they tend to have a lot of associated pain, and they'll have green, frothy discharge. What are the risk factors for BV? So we've said it's typically commonly in sexually active women, but it's very much associated to the use of a change in the vaginal flora. So it tends to be associated with use of vaginal products, douching, shampoos, bubble baths, but can also be more common in ladies who have had a recent change in their sexual partner or who had the copper coil. So how do we manage it? So for a first presentation, we may not rush in with swabs, and we can, as per NICE guidelines, we can treat it. So we can use oral metronidazole for 5 to 7 days. We can use intravaginal metronidazole for 5 days. My apologies, there's a typo on the slide. It's 0.75%. Now, if you're worried about poor compliance, we can even give a one-off dose of metronidazole at a higher tablet of 2 grams. With persistent or recurrent symptoms, the NICE guidelines suggest we examine and we do a swab, and we can consider the alternative. So if we've used vaginal metronidazole, we can use the oral form and vice versa. And if they're still having persisting symptoms, we may want to revisit the lifestyle options, but also consider some input from the gynecology team or the GUM team, who may want to try more specialized things like clindamycin creams and things like that. Next slide, please. So I think we've had a bit of a whistle-stop tour of common infective presentations. Now, I appreciate that some of these may be more familiar to some of you as opposed to others, but the most important take-home message that I wanted to kind of get across to you all is to think about these conditions, as I said, as a part of a spectrum, and remember that when we assess patients over the telephone or face-to-face, that we just get a sort of a snapshot of how they present, and we may not have the full diagnosis. So it's important to think about that they're somewhere along their journey or their timeline of their symptoms, and we assess them at a specific point. And so that can very well change, and we need to safety net them appropriately, and we need to ensure that we're thinking quite broadly about differentials, especially when assessing such patients over the phone, and not fall into the trap of just making very quick assumptions of, oh, it's a simple UTI, or it's a sore throat, it's tonsillitis. To think about those broad things and to try and think broadly about what medications they're on, and all the other things that might put their symptoms into context. So with the upper respiratory tract infections, we might think about self-help measures. With the urinary tract infections, we want to think about when to send an MSU and all the associated conditions we might want to exclude. With vaginal discharge, I think the most important thing is to take a really good sexual health history and decide on the need to obtain swabs. And that's pretty much the end of my slides. Any specific questions?
Thank you, Nia. That was amazing. Really great. Thank you so much. There aren't any questions in the chat box. Oh, here. Davina, thank you. What do you do for asymptomatic bacteria in non-pregnant females and males, especially the more elderly? Would you repeat the sample in case not a true MSU? Ignore it or treat it?
Thank you, Davina. That's an excellent question, and a really common thing that we encounter in primary care. So I've got a really good a clinical example I could give. I mean, sometimes we pick up these common bacteria called enterococci in the urine, and I often pick this up sometimes I've picked it up in much older men and women. And they may not be symptomatic with it, and it's quite interesting. You get the MSU result with sensitivities, and it can be a bit of a pickle as to whether we treat them. So first of all, in non-pregnant females and males, I'd say the treatment, if they've got no symptoms, then I would be more inclined to, exactly like you said, repeat it. But also just take a step back, especially if they've got an organism like enterococci. I found it is important to just explore their sort of hygiene measures and think about whether there's any cross-contamination. So sometimes I found, after exploring the history and really getting into the history in more detail, that some patients have all sorts of odd practices of how they wipe themselves down below, in terms of, after opening their bowels, they may, wipe themselves from the front, and there can be a lot of cross-contamination with stool bacteria in the urine. So it's important to just think about their sort of hygiene measures down below, but also think about whether they have any other kind of risk factors for, as I said, atypical organisms. So putting it into context, have they got any structural problems? Do you know if they've got obvious kidney stones? Because in those situations, sometimes they can have asymptomatic bacteria that is more significant. So these things will inform our management better. Most often the case, I found that you repeat it and it's fine. The MSU is often normal. But on the odd occasion, I have found that they do develop symptoms and we have to treat it. Hope that answers your question, Davina.
Amazing. Any other questions? Thanks, Anais. So thank you, everyone, and thanks for staying on. It's been really, really helpful. Again, Sadat's just said to sign up if you need to, so you can receive all the Training Hub recordings and information about any webinars that are coming up. Lovely. If that's all, thank you. I'll end the session there. Thank you so much, everyone.